On this episode of the podcast, Todd interviews Dr. Ben Fergus, owner of Cornerstone Health and founder of Grip Approach.
Hi guys, this is Todd from South Loop Strength and Conditioning, and I am up in the northern suburbs today, hanging out in Evanston with Dr. Benjamin Fergus, who is the owner of Cornerstone Health. Ben has also done a continuing education course that he's offering in terms of clinical education as well as some sport performance education. It's called Grip Approach, which stands for Global Rehabilitation and Injury Prevention. And Ben's approach has a lot to do with putting together a bunch of models as far as DNS, which is Dynamic Neuromuscular Stabilization. He spent time in Prague under Pavel Kolaj, learning that system. He's worked with Robert Lardner in Chicago, as well as Dr. Sean Allen, who is just outside of Chicago. And he's really put together a lot of these different protocols into a more actionable system. And he's teaching that through Grip Approach, as well as practicing day to day, helping folks move better from basic tweaks and little injuries to rehab to actually improving athletic performance. So we're up here to have a conversation just about the details behind how his methodology works, integrating research into actual practice, and really figuring out what's going on in this area that it seems like we should know more than we honestly do, as far as how the body works, how fascia works, how the nervous system works, and we really kind of don't. But Ben probably has better questions and better protocols than most people out there. So the goal today is to really get through some of that stuff and have a better framework for thinking about these types of things from an athletic performance perspective, an injury prevention perspective, and a coaching perspective. So Ben, that was kind of a long intro, but
yeah, good job with it though.
Yeah, trying to talk you up so people like you.
Right. I think you did an okay job.
Yeah, it shouldn't be too hard to make people like you. So give me a little bit, I tried to give some background on you.
Sure.
But I think one of the things that I'm really interested in for you is that you have all this education, right? From chiropractic school to these sort of mentorships under, famous world-class physical therapists.
Right.
Give me a background just on, how you got into this type of thing, how you approach learning, and what you found valuable from each of these different pieces of education.
Sure. So I guess just the basic education in school here in Chicago to get my doctorate of chiropractic degree. I went to a good school to begin with, and I think that's a good starting point for a lot of people. But the education can't stop there. Ultimately, the school prepares you to run an office day in, day out with a good 80% of the population. But my focus has always been on maybe that 20% of the population that either has an advanced goal, like a high-end athlete, or more particularly with chronic pain, chronic dysfunction, and complex presentations that don't seem to get better. And that's what really fascinated me, because all of my personal history with family and friends that had medical problems, it wasn't really the standard stuff that they were going in and getting better that excited them and changed their lives. It's those family members and friends that suffered for a long time and sought out care and failed before succeeding that really motivated me to continue to learn it and bring things in from other areas than my initial specialty. So pairing what I learned at school with some of these chronic, complex, or high-demand patient populations, I had to seek out the best available methods. And that's really what led me to Prague, to Robert Lardner's office in Chicago. He's also studied and taught extensively for Prague School, and under some basic mentorship of Sean Allen in the west suburbs. He also runs the popular social media site, The Gate Guys, and puts a lot of very valuable information out. So I've sought out these different areas that are slightly outside of my initial specialty to fill in the gaps and help the most complex and chronic cases.
Sure. So I think that's something that I see a lot in terms of, okay, here's a model that seems to basically work, but there's pieces that don't quite fall into place.
Right.
How can I improve the model to figure out those pieces? Do you have maybe a specific example of an athlete or a patient that you said, hey, you know what, my my model here isn't quite right, or it's not quite working, and that push you to search out more?
Yeah, honestly, I think it happens on a daily basis. Most methods, approaches, whether it's your entire program to become a doctor of chiropractic or a CrossFit coach, most methods are geared for like that 60 to 80% where you can make generalizations and people improve with. And I think that's okay because you have to have a workable model for clinic or for coaching, but it's that other percentage that can be so frustrating. And it does happen on a daily basis where we have to reassess the methods we're employing and say, what's a different angle we can approach this problem for the optimal solution? So, an example, I guess, would be with a shot put athlete. And we're looking for both the performance aspects of throwing the shot put, the power, speed, and arc needed to deliver that throw. But there are some major dysfunctions in the transverse plane of movement as well as the sagittal plane of movement. So limitations moving the hips back and forth in a rotation, that when we pair together the entire movement, we can say that this shot putter's main issue is shoulder pain, but that we can identify that shoulder pain has been driven from the opposite plant foot in the way he throws. And so then we just have to pick the model apart and say, we can't just address the shoulder because it's doing what it has to accommodate for the limitation in the plant side leg. Now that comes out of, gait analysis ad nauseum, just breaking down every little piece of movement. But I also think we can take that detailed breakdown and again put it into a format that we can make some quick observations and quick changes. That's kind of my drive in the educational courses, is to take the hyper detailed, nauseating focus and again put it into a workable model where you can have some consistency.
Sure. So to kind of elaborate on that example of the shot putter, I think this is something that I struggle with in coaching people, and you see a lot of debate and contradictory articles online with where in that case you may be able to say, okay, cool, you have this issue in terms of rotation that is potentially stemming from your lower extremity, and that's giving you issues in your shoulder. How come that happens to that person and not to another person who has the exact same patterning problem?
How come the shoulder pain isn't
right?
consistent?
So where's that threshold where it's like, okay, cool, like you do this wrong and have no problems ever, whereas you do this not even half as wrong as the other person and are just fine?
I would say there's a lot of complex answers to that question, but the easiest and most consistent answer really most likely comes down to diet and inflammation. If you have a high level of stress, you have to be able to counter that and heal on the inside. I think nutrition is a huge component. I don't get heavily into it personally, but we have people in our office who will break down a patient's diet and inflammatory state. You always have to match external load with internal defenses. So each individual's ability to heal is a big part of that. The second component to that is really mental. So let's say we drive the same tissue damage into one body and they have the same inflammatory state or ability to heal side by side. So same internal defenses, same external loads, but one person has prepared for this segment by segment and is okay with that movement, has been coached well. That can make all the difference in the world. So I think you can be really picky. You can break down movement. You can determine what works for one athlete that's not working for another with the same movement, but you can't ignore kind of the internal load and the internal healing abilities as well. That might not be the answer you're looking for, but I think I find reduction of inflammation to be a huge component of getting our chronic issues improved, but also keeping our athletes performing even when they have dysfunctional patterns.
Sure, yeah. I mean, and that sort of aligns with my own beliefs that I've sort of seen, where it's like, the dysfunctional movement pattern is a stress, and it's not necessarily the only stress on the person. And some people can handle the stress of a dysfunctional movement pattern based upon their stress tolerance, and other people can't.
Right.
And like you mentioned, there's a lot of factors that can go into that.
And it's an interesting question you propose of a theoretical basis. I'm not sure if I have ever seen two people throw a shot put that have the same biomechanics, or two people pull through a deadlift with the same biomechanics. There's enough variability based on the angle and shape of the bones, to the way they developed crawling in the first year of life, to the way they were coached at athletic development, But in theory, if you had identical, I think it would come down to inflammatory load and mental capacity for coaching.
Yeah, for sure. That makes sense, and that's kind of an interesting way to just parse the stuff we see in the real world.
Right.
It's easy to say, oh, like biomechanically, you're limited in dorsiflexion, so you're going to have this compensation in your knee.
Right.
But then you see in practice, like, actually, this person is limited in dorsiflexion and like can get away with it.
Yeah.
This person can't.
Of course. Yeah. And that's where you see too with a lot of your athletes, like if you really pick it down and pick apart the data, how many times do I see somebody who has flawed biomechanics, has very limited pain or perceived dysfunction, but they come in with an injury after they slept really poorly for a weekend because their entire way of healing has changed. And now what was like an under the surface dysfunction has been driving their symptoms after that. Poor sleep or thrown off diet, or a family member is in the hospital, something of the sort.
Sure. And on that note, what is your thought on people who are performing at a high level, doing stuff, again, in quotes, wrong? Right?
Yeah.
Where it's like, okay, you're throwing a shot put and you're throwing it, elite level distances, but you're doing it through a biomechanically compromised strategy.
Right.
What is your thought process around, correcting that strategy? Do we want
Sure.
to mess with this person's thing that at some level is working for them?
Yeah.
What do you think there?
Well, that's a really tough question. And you look at people who are dealing with golfers or even the basketball jump shot, where there's such a psychological component to it, as well as a lifelong training aspect to it. As your job as a coach or my job as a rehabilitation specialist isn't necessarily to go in and mess with what's been working for them, but can we build it up in a way that their body has more durability under it and that we can prolong their career with less stressors going into it. So I try not to change current coaching unless I see a major flaw, and then I try to open up that line of communication with their specific sport coach and what I'm seeing from a biomechanical aspect. But there are a lot of freaks of nature that we can look at and say, you're doing this all wrong, but you're beating everyone in the field. My question at that point is, how long can they beat everyone in the field before their body starts to deteriorate based on the forces that they're putting in? So it's a fine line you have to work. In what we do to approach overall fitness with the Grip Performance Series and the Grip Clinical Series is identify 4 zones of neutral reference. And we found that we can alter 4 areas of the body, make them function along our guidelines of relaxation, coordination, and elongation, and not dramatically alter performance negatively. As far as a golf swing can be done with very few modifications, yet if we modify these neutral zones of reference, we see really good biomechanical changes throughout the body without them having to recoach their entire swing. So I think it's making the right choice without affecting dramatically the overall coaching of their sport.
Sure. So you mentioned these neutral zones of reference as far as an assessment piece here. Can you elaborate just on how you assess people in terms of, someone comes into your office and says, hey, listen, I have a shoulder problem, or, I'm not like really injured, but I'm sort of tweaked up here, or like I just want to perform better,
Sure.
or anything like that. Like what do you look for in terms of
Well, let's break those into 2 separate categories. Let's say category 1 is the athlete comes in and says, I feel good, I perform well, but I want to perform better and always feel good, right? Maybe that's you saying that you're in pretty good shape, but you want to stay that way and maybe improve your fitness goals. I love to see athletes and patients with that drive. And when they come in, our goals may be similar to the patient with an injury or in pain, but we get to address it with maybe more dynamic and fun methods to get into it. So we have basic requirements for all of our athletes, and that includes the 80-year-old patient that wants to be able to get out of their recliner and the high-end CrossFit athlete, you name it. They're all athletes in some way, and we have basic requirements at the neutral zones of reference. The reason we've established these 4 zones of reference is in all the diverse areas of study, I found that methodologies intersect at these points. every major pathway of healing and rehabilitation has an opinion about these 4 points. And so we can break down these 4 areas under the view of many different methods and say, okay, here's where this method says the same thing as all of the other methods, and here's where they fight. And then we can start to look at the data between where they're different and find actually what I think is a pretty consistent way to coach those 4 areas.
Well, which 4 areas are these, by the way?
So the 4 areas, the first NZR is the lumbopelvic core, and core is a hot word, a buzzword, but essentially we're looking at the pelvic floor to the diaphragm and all the muscles around the abdomen, the obliques, the rectus, and the erectors. The second NZR is the shoulder girdle. We have primary focus around the shoulder blade, scapula itself, but we'll also look at the clavicle and the glenohumeral joint. The third NZR is the craniocervical junction. You think neck and head and the overall driving of position in sport. And the fourth NZR, really powerful area of treatment, is the foot. And we look for the essentially biomechanical tripod of the foot, equal balance between the first MPJ, the fifth MPJ, and the calcaneus. And on top of that, we want ankle position to be well centrated, and we want to be able to have a spread and elongation of the toes without clenching. Those are our 4 main NZRs. We train them in detail, but also give our patients and those who we teach in the courses easy ways of accessing those, so that when you stack the NZRs, stack really good function in those spots, the rest of the body starts to respond automatically. So if an athlete comes in with no pain and just goals of increased performance, increased durability, we got to make sure they can stack their NZRs, have really good function at those 4 areas, and then be able to take a sharp increase of demand without altering those neutral zones of reference and breaking down their system. That's a great place to start for my patients in pain, but especially with those athletes.
Sure. So you kind of have a very specific thing you want to see in these 4 key areas, right? Basically,
right.
the low back and pelvis, the neck, the shoulders, and the feet, and you're sort of watching to see, what dysfunctions are you creating in those areas, and because most people are going to come in and say, listen, like I'm tight here, or
right.
I tend to tweak my neck, or like I kind of pulled something, or
sure.
like I pinched a nerve or something. So these are sort of the the things that people are saying,
right?
And at some level you need to listen to that, but you're more concerned with what's happening in the.
That's a really important switch for sure. Because if somebody comes in with pain, they want you to look at it, touch it, move it around, and see what's going on. And we do that. We evaluate areas of pain as if they were areas of injury. But ultimately, pain is a big fat liar. It's great. Pain's beautiful. It protects us. It gets us thinking about things differently. But it's very easy for pain to drive things the wrong direction. And we see that all the time in pain-driven clinicians and pain-driven athletes. You can't judge your quality of movement based solely on how it feels. For example, somebody with like chronically tight hamstrings, or the feeling of chronically tight hamstrings, may have beautiful mobility in the hamstrings, but neurologically speaking, they're not comfortable with the way they control the hamstring. So it feels tight. They feel like they always have to stretch into it. But ultimately, I view that as poor coordination of the brain to the body. It's not always a length thing. Something can feel very tight and be extraordinarily flexible. So if an athlete or a patient can't establish neutral zone of reference, then they do feed strenuous activity and decentration into the other areas of the body.
And so can you just say what you mean by centration?
Yeah, so centration, there's a few ways of looking at it, but the best definition is a position of maximum articular contact. So if you think of a ball and socket joint, you always want that ball to be well centered and positioned in the socket, not rubbing against one edge, not rotating out of position. So when you have maximum articular contact, you can put an incredible amount of force through that joint without deteriorating the bony structures and with creating a good vacuum of force to make the muscles work well and make the joint move well. That would be centration. You can look at centration at every single joint in the body. It's easy to look at in joints like the shoulder or the lumbar spine, but you can evaluate somebody joint by joint to see if that position's present.
Sure. And I interrupted you. You were talking
That's
about basically the nervous system's relationship to joints that might be decentrated.
Yeah. So whenever possible, we like to take pain and work with our patients and our athletes and say, let's take this pain and put it on a shelf for a minute. We'll take it off the shelf and look at it again when we need to. Let's put it aside and let's see if you're able to perform the necessary tasks for what you want to be able to do. Now, when we evaluate a functional range of motion, that's the same for our athletes as it is for our general population. We know based on a lot of different studies and clinical data that every human with an average bone formation should be able to do an X number of tasks without decentrating or deteriorating their neutral zones of reference. So we can start with a basic screen for our high-end athletes and our patients, and then somebody that has a specific task, whether it's a work task or an athletic task, we can test beyond the functional range of motion into functional, suprafunctional range of motion. And that's something that's beyond what the average person needs to prepare for. And we can say, if you want to be in the lowest position of your squat, you're demanding a certain amount of mobility from each of your joints. That's not just the physical mobility of the joints, but that's whether or not your brain can control that position. Can you coordinate a centrated drive into that extreme position, or is some neural pathway limiting you from getting there?
Sure. And so say someone comes in then and you're evaluating them and you see, you know what, you just can't control, your low back.
Mm-hmm.
When I'm watching you go through these movements, you're just, decentrating all the joints there,
Mm-hmm.
completely giving away your position. And, just sort of elaborate on the potential consequences as far as the nervous system
Sure.
experiencing threat there. Why do people lose the ability to control these neutral zones of reference? What are they doing that they can't maintain a good position in these key areas,
Mm-hmm.
and they're giving them a way to accomplish other tasks?
Open up some big topics here, Todd. So if we look at NZR1, lumbopelvic positioning and function, that's a common one to be in a poor position for athletes in general population. One of the requirements for the first neutral zone is that you're able to descend the diaphragm to push into the abdominal canister and increase pressure from the top down rather than just cinching the muscles of the transverse abdominis, obliques, and rectus in. So if somebody can't create pressure from above and they begin a clenching response at NZR1, when you increase demand, that form of stabilization, the clenching, concentric collapsing type of control, is spread throughout the body. So when we look at the way the brain functions, that clenching, closing type position is similar to what we see in cerebral palsy, post-stroke. Patients that have had a severe concussion, they start to return to these early developmental states where they can't elongate, open, and stabilize their body. So that's one way that the brain can kind of close down movement from a superficial pattern that we've introduced ourselves. Another way that this may happen is if a patient or an athlete is unfamiliar with a movement because they haven't done it in years and years and years. If you take somebody who wants to get their deep squat going and they haven't been an athlete for 10 years and you're training this, there's going to be some initial barriers to getting that movement created because the brain is so efficient that it will start to shut down ranges of motion that you don't currently use. We see that as a hardening of posture. In my theoretical approach, joint restrictions that chiropractors mobilize are a hardening of position. It's a way our brain has become more efficient by locking down a range of motion that we don't currently use. So sometimes we have to hit that structure and get it moving in every plane of movement, but we can't just leave it at that. We have to get it moving and then tell the brain, it's okay to move here. You have to do it frequently. And if you want to keep it, you have to do it frequently and increase the load on it.
Sure. So we end up with these positions that are restricted, right? Where it's the brain is saying, you know what, like, you don't need this, or potentially maybe you hurt yourself in the past,
Sure.
so we're not going to let you go there again.
Yeah, previous injury is huge.
Yeah, what's the difference in terms of the mechanism for that, right? Versus
Mm-hmm.
like, this hardening versus, okay, I sprained my ankle 15 times and
Right.
now I have issues in that joint.
Yeah. And fear avoidance is huge. And a lot of times we don't realize that it's fear avoidance. The person themselves, they don't realize they're avoiding that because, they were bit by a snake, or they sprained their ankle bad. They just know that they have to protect that ankle and that it's locked down. So I try to flesh this out in my evaluation. And typically we see that if there is not a huge fear avoidance response in an area, that the response to a neurologically driven rehab program to drive a new range of motion goes really quickly. But if we put the patient through a range of motion and they're limited not by the joint position or the soft tissues, but they're fighting back away with their activation of the muscle, we see this a lot in the ankle, then often that's driven by a fear of the end position or a lack of use in that end position. So ultimately, we have to change angles. We have to back up and change their relationship to movement. With some of the complex patients, I use very vivid imaginative cues that they can relate to. For example, a patient of mine had a very severe concussion. She was equestrian, was thrown off her horse, severe concussion. We're teaching her how to move again, stand again. Colors are very vibrant for her. She can still relate to colors. So we give her cues like glowing her toes red and then drawing a line with her glowing toe along the ground towards her nose. And then we're approaching the body and the brain from a completely different angle. She doesn't have to think about toe dorsiflexion, ankle dorsiflexion. She just has to paint a picture of how her body is capable of moving and then allow that movement to happen. So sometimes these creative cues can really be a way to break through the barrier of previous injury. Now, I have some patients that will also say, I'm here because this auto accident that I was in 25 years ago is acting up again. And that's so common to think that previous injuries can be reactivated 25 years later. And I'm sure in some ways we can still continue to have a healing response, but most of the times that healing response is a mental approach, a mental fear or reactivation of what they were feeling at the time. So when a joint is actually broken or altered, you can have a structural limitation that stops the movement. But the way that you coach the body around that movement or through that movement, that limitation, can actually alter the joint. You can change the way you contract the muscles to create more joint movement, even when the bones are bumping against each other. And it's usually very rare that a joint is limited purely by bone bumping against bone and doesn't involve the way the muscles control the joint and the way the brain is comfortable with that entire system. So creative cueing, creative coaching is vitally important with previous injuries.
Sure. So say we have someone who, you see that they can't control their neutral zones of reference, and you're sort of evaluating them, and they have potentially a combination of joint restriction, muscle tightness, poor understanding of how to actually move, like you mentioned, with proper contraction of these muscles. And then you as a clinician then can say, okay, do I give you corrective exercise? Yeah. Do you need quote unquote strengthening? Do you need manual therapy? Do you need some form of joint manipulation? You have all these different options as far as trying to reset these improper patterns or mobility restrictions. And how do you start to filter through what people need?
Okay, so when I evaluate someone, the beautiful thing about the NZRs is so far in my application, which has been a diverse group, everyone is capable of creating a neutral zone of reference in those 4 areas. We may have to do a lot of modification to create that position, but ultimately each person has a position they can go into where they can create a neutral stability in all 4 of those zones. So the biggest thing for me in the most complex cases is to give them an initial victory. That means putting them in a position where all 4 neutral zones are working together and are stacked, and then increase demand on it. If you start day 1 with a victory saying, look how well you can do all 4 of these areas, and we can make it harder for you and you respond well, then you've already started the ball rolling for a better emotional response to what's going on and more potential for healing. I think this applies to training as well. If somebody is really crappy at their squat, you don't just coach the squat until they're in tears walking home saying, I can't be an athlete, right?
You made me squat. Help me.
That's right. That's like the easiest way to lose a client and for them to give up on their own body, right? So you have to find a place where they can have a victory. And for me, that always starts at the NZRs, because everybody can establish an NZR. Not everyone can squat, but most people have a position where they can feel good stability there. So then we establish the NZRs, we increase demand, and then we say, okay, what are your biggest limitations of movement that you need that start to deteriorate the NZRs? So for a lot of my patients, it ends up being some issues in the hip where they can barely move the hip without it completely deteriorating the neutral zone at the foot and the neutral zone at the core. So then we say, well, let's put you in this victory position where everything's working and gradually increase the demand of hip flexion, hip extension, etc. Once they can train into it, we can say, now we're down to actually what structures are limiting the movement. Your brain is aware of what you need to do. You're starting to do it. Then let's start to break down the tissue barriers and the joint barriers to allow freer movement. Rarely, if ever, in my office do I take a joint that's not moving, adjust it, and say, go live. Because ultimately, the brain is going to say, okay, you gave me movement where I have created this protective pattern of locking down. Now, what do I do with it? Am I going to move into it naturally a bunch of times? Usually no. Sometimes the body has an adverse effect and just starts to lock that joint down again. So I use joint mobilization and tissue mobilization as a way of increasing the picture that the brain has of where the body is in space and what it's capable of doing. So they're paired together. I like to start my patients with exercise first to free up what the brain thinks the body can do and really isolate where the issues are. Mobilize the issues as needed, treat with anti-inflammatory acupuncture, etc., and then again, put them right back into exercise, move into the gains, get the brain loving the gains, and then increase demand.
Sure. So there's a common distinction between mobility and stability issues
Right.
there, right? So just to give kind of a quick definition, a mobility issue would be something that a patient would not be able to create, say, ankle dorsiflexion on their own, and then if you as a clinician try to move the joint into dorsiflexion, it doesn't actually go anywhere, right? And then stability would be that they can't create it on their own, but they actually have the range passively, or potentially in a different position they can create it.
Mm-hmm.
However, as you start to get into some of these reset positions that you talk about, there's much more of a gray area between these things.
I think
where
there really
things that appear to be something that's like jammed or more physically restricted, it will actually reset itself based upon doing a certain exercise or a breathing pattern.
Mm-hmm.
What do you think is actually happening in that situation?
Yeah, I think that gets into a key area where perhaps our approaches that we go through in grip approach may differ from the standard definitions, and there is that somewhat uncomfortable gray area of saying some really cool stuff's going down right now. What's the best evidence of actually looking and defining what's happening? The distinction between structural limitations and stability limitations, it is a huge gray area. This was a huge realization for me that I could palpate somebody's spine and feel a cervicothoracic joint that just would not allow any extension at all, and they had to give up excessive movement in the neck and low back to overcome that. And then instead of just adjusting that, putting force to the joint to break it open and move it, I could put them in a relatively simple exercise position that use the brain controlling the body from head to toe, and within 15 seconds to 60 seconds, I could start to have mobility in that joint again without touching it, without directly putting my finger on that joint. I think that created a big gray area that we're still trying to define exactly what's going on. But one of the ways I look at it, at least in theory right now, is the physical properties of what happens with muscle contraction far away from a joint versus near the joint in centration. What we know is that as we increase the moment arm, we're essentially increasing the lever arm. So the muscles further away from the spine are capable of a much higher compression at the joint than those smaller fine-tuning muscles near it. And when the superficial muscles are in a tightened protective state, they lock down the joint so that even on palpation, it may feel like we're hitting a joint barrier or a connective tissue barrier, when really it's the way the brain is coordinating muscle control around that joint. This happens a lot in the big toe for hallux dorsiflexion, where the muscle imbalance around the joint creates the locked joint position. And in those cases, I want to make a connection where we can use a broad neurological exercise that, again, in theory, accesses subcortical patterns. And by doing that, we get a natural retuning of the muscle contraction around a joint that creates joint movement or decompression of the joint, and then our actual limitation in the connective tissue and in the joint itself becomes less or more accurate, so that we're not palpating, does the brain like this, or is it purely in the body? So that gray area, I don't know if I have a key article I can point to you and say this is exactly what's going on. And I'm not sure how a study would be formed in order to highlight that. But we see really good clinical results when we work brain down before we work body up.
Sure. And to kind of elaborate on that as well, I mean, based upon that answer, even if you may not be someone who does a ton of joint manipulation, that sort of explains why people may be getting results with joint manipulation sometimes.
Sure. Yeah.
Similarly, a lot of physical therapists are prescribing, just TheraBand, external rotations, clamshells, a lot of stuff that's effectively concentric exercise of stabilizing muscles, which doesn't seem to align with this model.
Right.
However, at some level it works. There's studies showing that people are getting results from this. Why do you think that works for people?
When it comes to movements that I dislike, like maybe a clamshell exercise where it's driving a lot of superficial muscle tone in a pattern that's different than the way our brain really likes to function, there's a couple reasons that works. One is that you're getting the client or the patient to move the part of the body that hurts, and you're there holding their hand and helping them. And that's really powerful from the mental part of physical exercise, to say, I can actually move in a way that previously I didn't think I could, and I'm safe, I'm okay. So that's part of the reason that general movement with resistance is effective. Also, just increasing the blood flow, the muscle activity, the joint activity in the area is going to have some positive physiological effects. But when we look at the physics of how that joint motion works, we know that we are using muscles that create excessive compression of the joint, versus I could coach sort of the same activity, rather than using clamshells that concentrically clench the glutes, I could put a patient in a rolling position from high oblique sit, which is a really foundational exercise for dynamic neuromuscular stabilization, where they have their hand on the ground, their knee bent in front of them at about a 90-degree angle. And rather than just pure abduction, external rotation of the leg, I now have the patient thinking about rolling forward, looking at rolling forward, elongating the body to reach for something in the plane of movement that the glute is supposed to work to centrate the hip. And now, instead of just giving them this isolated tunnel view of what the hip is doing, We have the whole body working together for a unified goal that demands normal activity of the hip. In this way, we get a more durable change because it's part of an entire system of movement, not just a tiny isolated movement. And so whenever possible, I like to branch out and say, what's the furthest we can work away from the dysfunction? Can I do something at your hand that makes your foot work better? Because if I do, then I have a much stronger subcortical integration of that movement. And subcortical or non-conscious integration is what allows athletes and patients to keep their gains in their activities of daily living.
Sure. So you mentioned these DNS positions, right?
Yeah.
So there's a lot of exercises that you utilize in your courses that are influenced by positions from the Prague school.
Yes.
And the DNS courses. What is so fancy and special about these positions? Like you mentioned the high oblique sit. There's various side-lying positions, laying on your back, squatting, all that type of stuff. Like
Sure.
What happens in these positions that enables change?
Well, I'll give you my opinion of this as a DNS practitioner, somebody who's studied with them extensively, and also with the skewed perception of this is how I utilize them and see them in office. So ultimately, the first year of life, and you can expand that to the first 4 or 6 years of life, but the first year of life, we know that across the board with 70 to 80% of healthily developing nervous systems of babies, that they do similar actions at similar times in their development. And that points us to the idea that maybe there's some programming to this, some inborn motor programs that help the child turn over around the same time period, coordinate muscles to go into a sitting position around 10 or 11 months, and eventually pull up to standing and walking with contralateral patterns.
So you're telling me we're not just a blank slate?
I don't think so. So what we see also, like look at a sprinter, right? Sprinting is the highest demand in a shortest period of time in running. So if you look at a sprinter, you're not just looking at a hip moving in a sagittal plane, a shoulder moving in a sagittal plane, and the angle of the body. There's a whole slew of automatic, non-coached functions that have to happen for sprinting to work at a high level. And when you look at the best sprinters across the board that are using the most demand, you see very similar neurological automatic responses in their body. These are the same things that we identify when we evaluate 100 babies side by side that are developing well or may have an issue, is that there's some similarities in the way the brain controls the body. And so in my theoretical perspective, and this does align quite a bit with the DNS theoretical perspective, if we have set movements that our brains are moving our body through, then that's essentially the brain and the body working together to determine how big the body is, where it is in space, and what movements are capable and necessary for the body to do. And because you do this for at least a year as you're developing, you're getting thousands of hours of experience exercising and training the body and brain together with specific movements. So that's really cool because I can take you and you can tell me that you have a limitation in a hip movement in one of your exercises, and I can say, well, I know that based on development, around 6 or 7 months, you had to use your hip the same way. So let's put you in that position and see how you move. And if it's limited, I can then increase and modify demand to get the brain to kick into some of these old patterns that you spent time in the gym training when you were 1 year old. So it gives us a window into how movement was developed, how the brain views movement safely and efficiently, and how we can alter it without having to drive it through your head with cortical cues, and instead give you movements that you get some automatic response. And this is what I think is the coolest part about DNS. It allows you to train the same movements as any other sport allows you to train, but allows you to do this with the most coordination from head to toe, the least amount of joint compression, and ultimately the least amount of cortical frustration in training that joint, because we have what's termed automatic or subcortical changes.
Sure. So basically, you're saying that these positions are somewhat fundamental to human movement, and so you can get good insight in these positions in terms of whether or not someone can create them, and then also you can use them to reactivate patterns that someone may have built an improper pattern on top of. Is that a reasonable summary?
I don't think I would disagree with much of that, but I want to highlight that it's not necessarily just a position. So the position is important because that's giving information to the brain of where the body is. But ultimately, the way you move out of that position and the forces put on the body help to activate certain patterns of movement. So squatting, for example, is a developmental pattern, but just working on a squat doesn't necessarily bring all of the benefits of developmental training. We have to put you in a position that's similar to that, and then approximate the joints and drive force in a way that's consistent with the neurological patterns of ipsilateral movement and contralateral movement. The rest of your statement I totally agree with. It's getting you to move in a more natural way that your brain has already trained and already prepared for.
Sure. And then to elaborate on that, what happens as far as different movement patterns in the brain where, we at some level we have these fundamental patterns that pretty much everyone is born with at some level.
Sure.
And then we develop a wide variety of compensatory patterns on top of it. We can move through a squatting motion one way when we're doing, say, a back squat. We can move through it another way when we're picking something up off the floor. So we have all these different ways that we can create these ranges of motion. How does the brain select which one to utilize, and how do we potentially change our ability to do that?
Yeah, another great question. So there's essentially 3 levels of motor control. The 2 primary ones that we're talking about are the subcortical level of control and then the cortical level of control. Subcortical is things like gnostic function, trying to differentiate what a quarter feels like from a penny, being able to activate the body without thinking of it, versus more of the cortical changes are patterns that you have created or demands that you have on your body. And cortical function is where we have the most variability from person to person. And that's totally necessary because your femur is a different angle and length as my femur. Your ankle is a different shape than my ankle. So if we only stuck to these like primal subcortical primitive level of movements, then we would be just driving immense dysfunction through our bodies because they're not built the same way. So you have to have cortical variation even on these subcortical movements to allow your body to move the best way for you. Freedom of movement essentially is a cortical choice. So when we look at the patterning of a key activity, what I look for is not do you look like 10-month-old Todd looked when he did this. That because you're a different person, your muscle structure, all of your movements are different.
My head was probably the same size as a 10-month-old as it is now.
That's possible.
My parents took me to the doctor because my head was so big.
Hydrocephalus?
Yeah.
Okay, so I can't compare you to 10-month you and say, why can't you be in that position and activate this way? But what I can look for is your biggest deviations from that ideal subcortical patterning. So for example, if I look at the squat and you have a big shift of the pelvis, a wobbly knee, or clenching toes, I can identify that in this position, there is a harder time matching ideal cortical stabilization and subcortical stabilization than you have in a different position. And I can say, now what are our barriers? Did Todd hurt his hip or a knee in the past and he can't get over it? Does he have an injury to the joint or an injury to the tissues? Did he have really crappy hand-me-down shoes when he was a teenager and start to push off that foot differently? And then we can break that apart and say, maybe we can remove the structural barrier and get the brain moving in the pattern that it was trained at in the first year of life, and then reassess that squat and say, okay, now your deviations away from ideal are less pronounced. There's less leaking of your kinematic energy from the foot to the hand where you generate force, and ultimately less escaped force means less potential for tissue injury.
Sure. So to kind of go, I guess, into your story more surrounding a lot of this DNS stuff, you actually went over to Prague to
Yes.
train under Collage. Can you just tell me, I mean, how did you decide to do that? Is Eastern Europe cool? Like, what happened there?
Yeah, boy, that was a trip of a lifetime, and I plan on repeating it this year and returning for 8 days or so to study in Prague. Prague's real cool. Eastern Europe's really neat. I think some things that were frustrating from a social political standpoint with the kind of overarching Soviet dominance in the area for a long time. I mean, we're talking Velvet Revolution, early 90s. That's a pretty recent history being the country that it is today. That's very fascinating because you can see a huge mixture of the way things were with the way the country is striving to be right now. And at least in my view of it, I think that may have led to some of the creativity we see in their way of addressing human movement and neurological driven movements. Is that they had a simple system, meaning I don't believe that there was the technology and pharmaceutical drive that we had here in the States at the same time. And there was a lot of treatment by hand and evaluation with really good eyes. And that was through Professor Collage's mentors that handed down that system. And then he saw it and approved upon it. And hopefully Professor Collage will hand it down to the next generation of people that really break down the movement, incorporate the newest research, and increase from there. So from a social standpoint, the best beer I ever had was in Prague. Probably the best sausages I've ever had were in Prague, and beautiful views, beautiful architecture, great place. If you have a chance to visit, I definitely recommend it. The cool thing about the program is that you put 30 doctors and trainers from all over the world in the basement of the biggest hospital in Europe and say, okay, we're going to bring everyone's perspective together for 1 week and show the similarities and the differences and how to increase your skill and your adeptness at just evaluating movement in general. And that was an awesome experience. Here we are in a first world country with fairly good economics, and our physicians are paid well in general here. Our trainers are paid well in general here. And then I'm meeting with colleagues there that are from different parts of the world, and they've given up an entire month's salary to be able to study for a week in Prague. And it's a huge investment for everyone's there. Time investment, mental investment, financial. But this is a recognition across the world that there's really cool and important things happening here. And we're all meeting together under that premise, essentially. And so Professor Collage's team and Professor Kobasova is a really big part of this, organizing the event. They bring together over a dozen different physiotherapists with slight differences in their specialty, from pediatrics to athletics to brain injuries to vertigo and digestive approaches. And they put everyone together and say, you're going to spend 2 or 3 hours with this person and this person, evaluating each other, evaluating patients, and seeing how the best in the world do it. And yeah, so great experience. I really honed my skill a lot and was challenged to break out of the mold of how we work here and say, can I be great in your model? And then what am I going to take from that to incorporate into the way we can practice here in the States?
Sure. So it seems to me like a lot of what you're doing as far as your own continuing education courses and your practice is synthesizing a lot of information and figuring out, okay, how do I take all these models and figure out what to me seems like the best pieces of them, and how do I apply it? How do you decide what to read? How do you decide what courses to take? You know, what are resources that you trust, and how do you find new ones?
Yeah, and I think that's going to be different for a lot of people. That really is the biggest challenge for a lot of people that are trying to be the best is that you seek out the best programs and the best books, and you say, wow, all of this is cool and important. How do I use it from day to day? And that's where I have focused a lot of my energy in creating Grip Approach, and also in the day-to-day operation of my clinic, is saying, can we take the best, identify where they intersect, and make a system that works from day to day? That's Grip Approach. That's what we try to do. But how did we get there? Ultimately, I had great mentors, and I try to be a great mentor for anyone that has those same goals that I had of being the best in a couple different topics. So some of the key resources for me, there are 2 great books by Thomas Michaud on biomechanics, specifically the biomechanics of gait. He's got one that's called Foot Orthoses and Other Conservative Management, and one that's called Human Locomotion. And these, if you're not careful, will put you right to sleep because they're so detail-oriented. But if you approach it and you say, okay, this has a lot of the biomechanics answers that no other source has, you can start to peel through that and really get a good idea about how every joint in the body moves. Another real key source for me was reading through Professor Levitt's original texts on evaluating skin tone, muscle imbalance, and Yanda's text as well, and just looking how you could increase your visual and physical skills and then correlate it to the biomechanical model. So I read a lot from a lot of different sources, and then as I read, I try to take the sections that seem the most profound to me and then compare them to the most profound areas of other avenues. How does this really profound neurological statement match up with what we know from the best biomechanical sources? And if I want to spend all my energy on one area, it's going to be where everybody agrees. I mean, that's your biggest chance for success, is saying, here is the intersection where acupuncture agrees with DNS, agrees with chiropractic, agrees with physical therapy, and coaching. If they all agree here, that's a great starting point. So that's kind of the way I piece it together.
Yeah, that makes a lot of sense. You also read a lot of research studies.
Yeah.
And how do you access those? Which one? Sure. Again, because it's one of those things where it's just this. You look at the list of studies pending for publication. It's like, good God, there's
a lot. Yeah. I have a major love-hate relationship with research. Primarily a hate relationship, but one that I keep up with. My major searches are on PubMed. If you just Google PubMed, you'll get a good search engine. There, I believe, is a paid version and a non-paid version, and that is a great source of studies in the medical world, and you can even find some athletic-driven studies in there. They organize them by the level of evidence. Sometimes you only get a title and an abstract. There is access, free access to a lot of articles on there as well. So because we're looking at research from around the globe over a period of several decades, it is hard to read through them to get a perspective. Ultimately, if you can find a meta-study, you have the highest level of evidence, because that's a study that's evaluating hundreds or thousands of other studies to give you one opinion. That's also very dangerous, because if you look at the variabilities of any large group, you have to cut out the borders to get a unified view. And that's where I find the gray areas to be very valuable. In a meta-analysis, you're relying on the baseline data as well as the author's interpretation of the baseline data. And one example of a study that drives me absolutely crazy and gets referenced all the time is the study that looks at the force required to actually stretch or lengthen the tissue of the IT band, which is a favorite spot for a lot of people to foam roll. And so they essentially say that the force it takes to create a stretch elongation in the connective tissue of the IT band, you would need like a cement roller to actually make a difference there. And I think a lot of perspectives say, okay, well, we can't change the connective tissue of the IT band, So that's what the evidence says, and so we shouldn't do it, and it doesn't make sense to do it. But that's a very narrow view of the research. What that lets me know is that, okay, clinically we know that we have an effect when we stimulate connective tissue. This study says the effect is not elongation of the tissue itself, but we know the effect is still there. So now I gotta type into PubMed massage or friction and connective tissue, or stretching and connective tissue, or acupuncture and connective tissue, and see what evidence do we have that supports a physiological change in the connective tissue. It doesn't completely close the book on changes in the connective tissue, because we know for years and years and years that there is a positive change when you do therapy there. We just know that a little piece of that may not be accurate, and now we have to complete the view. So I try to start with a problem, go into PubMed, get the biggest amount of research on that problem, and then attack it at many different angles and align kind of the overall interpretation.
Sure, yeah. So it sounds like one of the challenges you sort of try to work through is parsing out the difference between mechanistic explanations of things versus, okay, is the research shows that this works and there's a reason for it, but it might be the wrong reason.
Right. And we also always have to take into account that studies primarily look at what is testable, right? And I really don't think that at this point that everything is testable. There is that X factor in athletics and in clinical care where you have to say, okay, almost everything we're doing aligns with the best research except this. And that little category that's unsolved, I think we're going to continuously try to solve that for hundreds and thousands of years from now. And so we have to accept that the evidence is not the final word. It's the best we know today. And we have to pay attention to it. And we have to strive for better. And we have to realize that we can't test everything.
Sure. If you could do any study you wanted with unlimited funding, compliant participants, all the variables that are challenging, what for you would be, just a massive win in terms of, I'm trying to really understand what's going on in this question. Like, I really want to know what changes here. What would you run?
Well, it's hard because I think the one thing I would add to your list is if it was possible to test it, right? Sure. Not just financially, but like, can we have a reliable structure of a study to do this? The idea of joint centration still has, we have to say the theory of joint centration, because it is a hard to define concept. What's unique is I'm discussing to you force through a joint in malposition, but then we know that you can put an extraordinary amount of force through a joint in athletics and still be in good shape. So when we look at that, we then have to think about torque force and shear force in a joint and how that relates to joint position. So if we said we could solve every variable, I would want to look at the effects in a joint with a high load at different angles of shear and torque force, and essentially say, what is the big change that's happening with joint centration? Why exactly does it allow us to handle much larger loads with less potential downfall? We only have that in theory right now. There's some studies that round out the picture, but I'd want to look at that in a little more detail.
Sure. So what would you actually be looking at there? Would you be looking at, tone of the muscles surrounding the joint? Would you be looking at potential injury or degeneration within the joint? Like what is all of the above?
Sure.
What pieces are you looking at?
Yeah, I think at this point it would have to be all above. It would be a very hard study to form. I would look at my definition, my clinical definition of centration, essentially trying to see balanced muscle activity around the joint without concentric clenching, using the least amount of force to balance the joint is a good sign that the joint is in adequate position. And then I suppose we'd be looking for where the force is distributed between the two bony surfaces when you add force to it. And is that a small dot of central force Is it wide distribution? Does the vacuum effect of a joint change the way the force is distributed? And then over a period of time, where does where does joint degeneration occur in that spot where the force is distributed?
Got it. So let's talk about this grip performance course
Yeah.
as well. So you have a clinical model, which I've
Sure.
taken 2 courses based upon that, which is primarily for chiropractors, physical therapists, people who are effectively, working with an injured population,
Sure.
and are probably licensed professionals to do
Right.
therapy and all that type
And
of stuff.
high level coaches like yourself that want to be able to identify the issue faster to know when to refer out and when to train in house.
Yeah, sure.
I think you did great in the courses.
Yeah. I mean, and for me as well, I personally enjoy putting myself in courses that I don't necessarily quote unquote belong in.
Right.
Because I feel like I learn more since, everyone else has a baseline of certain education that I don't have.
Sure.
So I have to sort of play catch up and say, okay, cool, what do these people know that I don't know? So I mean, that's just my own, I guess, bias and sort of why I enjoy taking courses like that
It's
as well.
good to be uncomfortable.
Yeah, exactly. Where, I not to say I know everything about strength and conditioning, but
Sure.
I take a strength and conditioning course and I'm like, yep, like,
Got it.
Like,
Yeah.
okay, cool.
What's new?
Yeah. So I enjoy going outside of my
Right.
own expertise in that sense. But with this performance course, it's focused more on the coaching piece of all this type of stuff. Can you just elaborate on what that looks like in terms of, how are you teaching
Sure.
coaches these concepts?
Yeah. So we've seen a huge amount of success with the application of the grip clinical model by the chiropractors and physical therapists that have attended the course and apply it. But a good third of the strategies that we employ would fit really well in the training environment. And the goal with the performance courses is to say, can we remodel this a little bit and deliver it to a package that a trainer can take and use daily to prevent injury with their clientele and increase performance in a way that better aligns with current research, as well as the clinical model that hopefully in the next couple of years, the majority of clinicians in the area will be following. So in this way, I work with a lot of trainers very closely. We don't have time to do high-end training. I don't have the skill to do high-end training in my clinical setting, but the trainers that I've worked with that have taken these courses, I can identify the exact problem from our clinical approach and say, okay, we've identified X, Y, and Z. You know the training package that will make them the most successful. You know what to look out for and say, this is an issue for this patient. They need a little more focus whenever we do this exercise. And it gives people a working model where you can be safer. You can add demand to the body without fear of degeneration if you do it well. And it's really a working model to give you new eyes on the body, where you're not just looking at plumb line, you're not just looking about the amount of weight that's being put into the body, but how does the body work from head to toe with neurological influence.
Sure, yeah. So it's not necessarily a replacement or even a comment on, okay, like your CrossFit program or the intervals you're being prescribed on a track,
Right.
or doing kickboxing or anything like that.
It's not a replacement whatsoever. It's an additive and a refinement for everything else you're doing. The beauty of this is we have trainers that take the grip performance class that say, okay, I can take this entire model and now I have a whole new world of how I coach somebody through yoga. It can take you and your training of your CrossFit athletes and say, okay, I've always had an issue with this group of athletes doing this exercise. Now I have a new avenue of helping them improve, doing what they want to be able to do and what I want them to be able to do as a coach. So the goal is we're not going to give you a bunch of new ways of training your patients. We're going to give you ways to your clients. We're going to give you a way to coach them for more success. And I'll put the caveat, in theory, less injury potential in the way you move them.
Sure, yeah. So it's a step back from necessarily the X's and O's that a coach or a trainer may have as far as their
throw the plumb line away, throw the cookbook away. We're going to give you some structure to it, but make it an adaptable system that you can apply to any movement.
Sure, so you can recognize potential issues that, you can't, okay, I'm coaching you every way I know how on the deadlift, and you're still not doing it right.
Yeah.
You can take a step back and say, okay, is there a fundamental movement pattern
Sure.
issue restricting you from actually achieving this position?
That's right. And then the great thing about this, and we've had a lot of success when I've presented this in Asia primarily, is when the coach can identify the biggest issue, we then have the question, can this improve with brain down and body up training, or does it need a targeted structural intervention that I have to shop out to a good clinician in the area? And we train you as either an athlete or a trainer to identify really quickly, is this something that we can train into improvement, or do we expand our team approach to it? I do encourage like your high-end athletes to also attend a course like this, because a lot of the modifications of the NZRs are things that you can add to your personal practice to improve your athletic pursuits. And again, that may be an uncomfortable area for the athlete to go into, but that's where the brain learns and the body learns and it expands.
Yeah, for sure. So, Ben, if people want to know more about Grip Approach, what should they do on the internet?
www.gripapproach.com. We also have a Facebook page. We're new on the plane of social media, meaning I'm a little too old to get it all. So we're improving our social media feed.
Are you not a millennial?
Well, yes, I am. but my technology, my abilities with technology are fairly limited.
Got it.
So what we're working on right now is actually putting together quite a few YouTube videos targeting 60 seconds or less and saying, can we take the most complex methods and give you a 60-second view that you can incorporate into your training. So we've got two that we put up this week on a reverse push-up training and a front knee press into a wall. My goal beyond this for the training population is to say, can I put a 60-second or less video up with no words and only movement and make that a pattern that people can pick up and improve their training? I think what Steve Jobs did for computers and what the Japanese automakers did for the cars is kind of what I'm trying to do with this clinical view into training, is take the best available technology and make it work smoother, faster, stronger, better.
Yeah, that's a worthy goal.
Yeah.
And if someone lives in the Chicago area or northern suburbs, you're in
Sure.
Evanston, and they want treatment or an evaluation, or to just to hang out sometime,
Sure.
What should they do?
Okay. So my main office is Cornerstone Health in downtown Evanston, near the Davis Street train stop, parking nearby. So you can check out cornerstoneclinics.com to find our main office. We're working on opening a new facility nearby on McCormick between Evanston and Skokie that is clinician-driven personal and group training, where everyone would have a workup with myself and then drive into a skilled group training. Our main target population with this one is actually those who have had a long-term issue like spinal stenosis or sciatica, or maybe you're an athlete but your parents aren't and they want a safe way to start exercising before they jump into your CrossFit gym. We want to be a transition between the clinical world and the high-end athletic world and give a bigger population the benefits of exercise. So more info on that one soon, but look us up at Cornerstone Health or meet me at the local breweries.
There you go. The local breweries, the watering holes.
That's right.